to the other cat lab. Dr. Yoshimashi will be a virtual 3 French. So 5 Frenchies less. I understand 5 Frenchies less. Very complex classification. I think we have to do, as a club, we have to do something to make it easier. Can we see the second cat lab? No? Not yet? Not ready?
We could start with some details of the second case.
Okay, the case.
Thank you. I will introduce the fourth case as Mr. H. He had a history of heart failure and dyspnea, and he was a smoker, had a family history, had also an MI, and had negative T's infralateral. And he came to our ward with heart failure, and the echo showed a ejection fraction of 20 to 25%, and catheterization was performed, and that's the next slide, please. Vessel
nice.
Disease with an RCA that was subtotal, important lesion in the LAD and a functional occlusion of an MO. And we decided to give him a full revascularization and also treat the MO eventually to maybe get his MI better. Can I have the next slide? So on the February 3rd, the RCA was treated with only 21 milliliters of contrast and 5 French sheetless procedure. And next slide, please. And here I can show you, and I will come to that in my talk this afternoon also, the lean hemostasis we do here at our hospital with not with a Terumo bandage, but with just a normal bandage where we check oxygenation of the hand after just applying it and the next day. Next slide, please. Can I have the next slide, please? Thanks. So what you see is that if you apply the bandage directly after the procedure, and you then you see pulsations. But if you close the ulnar at the artery, then you see no pulsation. But at the next day, when you do the same procedure and you close the ulnar vessel, then you see pulsations. So over the night, this bandage will become looser and looser, and we see that we have really nice results where we have almost no already artery occlusions after this procedure. Next slide, please. We decided to do for this day the PCI of the LAD, and it will be a virtual 3 French, 5 French sheetless procedure. And I hope that they will be ready in the other room for live transmission. You don't, not yet. Can we go back to the other room, to Ferdinand, to see how far they are there?
Oh, they're ready.
Can we go back to see the results of the previous?
Dr. Yoshimashi, we are looking to you. We see you. We don't hear you yet, but we see you.
Do you hear me?
Yes.
Okay, the camera is not installed yet, but in a few minutes...
We are in the other cat lab, Ferdinand.
Okay.
We see Dr. Yoshimashi.
Okay, good.
Thanks so much for your support.
Do you have the case?
Yeah, we have seen the presentation of the case. And
The case
I think Dr. Yoshimashi is not aware that we are looking at him.
No, because he has no microphone yet. This patient has already been introduced to you?
Yes.
Okay.
Close to me. Okay.
You also have seen the previous PCI of the right coronary artery occlusion?
Yes.
Okay, good.
16.
Then you're all set. We can start within a few minutes. So the first patient this morning was a virtual 5 French with the sheathless, with the slender sheathed case. The second patient was a virtual 4 French with a sheathless 6 French, 6.5 French procedure. The last patient that you saw was 5 French sheathed and was the most complex patient of this day. And now you are going to see a virtual 3 French, which is a sheathless 5 French techniques. There are many ways to advance 5 French sheathless into the radial artery. You can, let's say, pre-dilate the radial artery, the puncture site with a 3.0 sheath, and then introduce a 5 French catheter. You can also pre-dilate with a 4 French sheath and advance a 5 French catheter. But Dr. Yoshimachi will show a true sheathless system with a long inner dilator, which is provided by Terumo. We also wanted to show this morning 5 French sheathless system from Medikit. We expected CE approval 1 hour prior to the live procedure, but it took, unfortunately, it took a little bit longer. So officially this product has not been CE marked yet, so we cannot use it. Here, what we use here is all fine. So, Dr. Yoshimachi, can you introduce your technique?
Okay, so actually we cannot get the CE mark of the total system of sheathless 5 French guiding catheter. It means 3 French virtual 3 French system. So today we cannot use that. So I prepared the long dilator like this one, and using the guiding catheter of 5 French.
Do you know if the long dilator is available in Europe? It's from Terumo?
I don't know. I'm sorry, I don't know. Can see the long dilator?
Yes.
Okay. No gap. So first, じゃあ2個のワイヤーと。
So just to clarify, the dilator is from Terumo and it is CE marked, and is that correct?
No, the system is produced by Medikit.
Yeah, the Medikit system is not CE marked, and here this is a dilator was brought from by Terumo from Japan. It's used there very frequently.
Check.
So what wire do you use here?
This guide wire is a 2.5 wire.
Okay.
Yes, because of the compatibility of the puncture needle.
Can we?
Okay. It's no resistance.
No.
Waar is de guide wire?
Kan de tafel even uit lood? Here we will change the position of the table. Yeah.
Okay. Yes, so easy. Yes, it's a guide wire. ポジションを普通にしていた方が見えます。Yes, yes, yes, it's okay.
Yeah.
It's okay. Okay. So, I want to use cutter, knife, small knife, for the skin. そのシステムをください。
There's also hydrophilic coated, the catheter that you brought.
Yes. It's okay.
Have you seen any allergic reaction with the hydrophilic coating?
Sorry?
Have you seen any hydrophilic reaction with hydrophilic coating?
Allergic.
Was described with a catheter a few years ago. An allergic phenomenon.
I don't know.
No.
Allergic phenomenon, it's not so many. Can you see the inserting the point position? Like this one.
The wire you have is a 25,
Yes. This is
and
25.
the dilator you have is not tapered on the 25, right?
Dilator is, yes. No, this dilator is compatible with 3.5 guide wire.
Yeah, so it's not tapered
Yes.
on the 25. That's the reason why you have to cut the skin.
Because of just only the compatibility of
Yeah.
puncture.
Yeah.
So I will exchange the 3.5 guide wire.
Again with this Terumo wire with the special.
Yes,
shape.
this is a special shape of guide wire of Telmo, like this shape.
Yeah.
That is Dr. Saito uses that. It's really liquid.
Very difficult. Yeah, maybe you need something to straighten the tip. You have sort of the base on. Oh yeah, here it is.
It's okay. So if you have, if no resistance, it's
Which kind of shape did you selected? EBU or
no. I like Jadkin's type guiding catheter.
Judkins?
いいですか？はい。ここ曲がってるんですよ少し。Okay.
Is it resistant?
It's okay.
Very slippery.
Yes. We have an AP. もうちょっと頭にして。
So at what point are you going to retrieve the dilator? Is that beyond the
Yes.
just in the ascending aorta? Or?
Yes. Now I'm leaving
Okay.
here because of a very long tip of the dilator.
Mhm.
So fair to note, to continue that question, how long is the dilator after the catheter? About 5 or 6 centimeters?
This is 530 centimeter.
Okay.
どこ
So
上
the
だね。
So you really have to pull it out before you.
yeah, I think
get
so.
it.
Otherwise,
Okay.
can damage the coronaries. But I see that it's still partially in the.
Yes. あ、ちょっと待って。これは何
So
あ、
now
親だ
the
けにする
dilator is removed completely.
はい。
Oh, heparin.
ヘパリン。just a moment. And we have to take care for the air incubation when using the small. Yes. いや、待って。
Oh, the display.
This is heparin.
Yeah, that's heparin.
Okay.
You can give it. It's
Okay.
5,000 units.
Okay.
Gaat het goed met u?
Ja hoor.
Ja, nou, de katheter die zit bijna waar die helemaal moet zijn.
Okay.
Gaat met de arm.
ちょいこう押してください。いや、まだです。ここだね。はい。です。Okay.
So can you go to...
So may I use the guide wire run through? And may I check
run
the-
through guide wire?
Yes. LA オクラによってできます。適当です。
So this morning we will only focus on the LED, not on the occluded fused marginal branch.
Yes. Thanks.
The patient has an ejection fraction of 20 to 25%. That's why we do the full revascularization in staged procedures.
テープ締めです。
Yeah.
真ん中、ここ。No.
You need the hypercode.
No, just only normal.
Nee, ja, de normale. Wat is dat? Ja, extra floppy.
Yes, please.
Ja.
こんなのかな。よし。じゃあ、すみません、お願いします。
It's proximal to that second diagonal. The first diagonal is very
Yes,
small.
so
Yeah.
our plan is just spot stenting.
Yeah, spot stenting there.
見沙汰をください。
Ferdinand,
Yes.
Marshall speaking. Have you any cardiac assessment in terms of viability assessment in this patient before revascularization? I mean, complete revascularization in such a fragile patient.
I don't have that information here at the moment. But this patient had a full coronary checkup first. I'm sorry, I cannot give you that answer now.
Ferdinand, I see some calcium exactly at the position of the stenosis.
Yes.
So I presume you will predilate, and if it's not opening,
Well, personally, with this amount of calcium, I do not predilatation, but sometimes when it's more severe, I do. Let me ask Dr. Yoshimashi's procedure here. But you, in all cases of calcification, you predilate, and otherwise do you use rotablator, or?
No, just only predilatation, please. So we.
His patients ejection fraction basically.
Yeah, very low.
It's very high risk. Yes.
No, but in general, I mean, not in this patient. No, so I think we will do a predilatation here.
Yes. 2.2, 2.5 balloon.
2.5 short
Yes.
balloon.
Yes.
Yeah, Eva, I've noticed that the
12?
guide wires are
No,
they're using a
short,
run
eight?
through.
8
I
to
know
a
that
10.
you use them a lot. Can you comment
10
about the differences
What have
between
you?
the run through and the BNW?
They have a quarter? Oh, we don't have shorter one. So 12.
Yeah, I know what you
Well-
want me to say. Run-through is hydrophilic wire, so we had, as we are obliged in France, we have complication session in our group, at least 4 times a year. And I think several times a year we present some perforation done with the hydrophilic wires, including these soft wires, even the whisper. And was the recommendation I give to my fellows is to always keep this tip of the wire in the radiologic field. I think it's very important to. It's not perforating by the tip. Normally, this is a loop, and this is really cutting the wall in the side branch. And we had some severe perforation with this kind of soft wires. So, my opinion is we have to keep it in the field of the radiologic in the radiologic field.
Yeah, but the difference that I found between the run-through and the BMW is that the run-through has a tendency to answer one-to-one for the torque, and that it's maybe a little easier to maneuver once you get the habit, because obviously when you've been using the same wire for 20 years, it's a little difficult to change habits.
You are saying that for me because I'm still using the BMW.
It's moving a bit forward. Isn't it?
Depression. More proximal.
So it's a 2.5 balloon
Yes.
Yes.
and semi-compliant, I presume, not.
Okay, depression.
Semi-compliant balloon.
Yes.
Not a non-compliant balloon. Not very compliant.
Just a question: if you want to protect the diagonal, is it possible?
This first diagonal is very small.
I agree, it's very small. But imagine you want to put a wire. Is it possible?
Yes.
Depression.
Yeah,
And you can
with 5 French, that's
redilate.
possible.
Also, you can put a stent with a wire in the side branch.
Yes. Only with, but you cannot do any kissing balloon. Or
Yeah, I agree. But
But
no,
you
there's
can-
no question about kissing balloon here.
No.
Just a question of
But actually,
keep it open.
with the O10 products that are available in Japan, you can do kissing balloon.
Yeah, but they are not available in Europe.
No.
So
But,
this is also a message for the companies here.
Yeah, absolutely.
If they,
But fortunately,
if we want to
the
slaughter
balloon-
in Europe, we need the material.
Yeah.
The diameter of balloon is very slender now.
Yeah.
So if we can select a good balloon,
Yes.
we can perform the kissing balloon technique with 5 French guiding catheter with conventional 14 balloon.
wire.
Yes.
Okay, good.
So I'd like to insert the stent.
Yeah.
3.0 and 15 or so. 15?
Yeah? 15?
Yeah.
Oké. Heb je een 3.015 Chemical Science?
15.
I don't find it so small, the first diagonal, especially in the patient with a 25% ejection fraction. So I have a bit of concern about that.
Ostium is good.
Yes, maybe.
I wouldn't be too well. I wouldn't put a guide wire in it. In contrast to you, because there's no disease on that
Yeah.
diagonal branch. It's got an angle that's relatively high from the LED. Do you think you would lose that diagonal branch?
So sometimes
We'll see, but
when
I
we
think
treat
it's
the
possible. I think it's
bifurcation
possible to
lesion,
use it.
I select the rigid stent like nobody and only making a small side hole with 1.0 millimeter balloon or 1.5 millimeter balloon. After checking the OCT or any imaging, it's not so bad. Some doctors is very worried about the deformity of the making side hole after making side hole the stent, but in my experience, only using 1.0 millimeter balloon or 1.5 millimeter balloon with nobody stent is very good. So
I agree with you.
okay.
I agree with you.
Okay. So today we serve the giants. So it's gone. Okay. Malfunction.
Yeah.
It's here.
Yeah.
撮影しますか？いや、いいですよ。うん。ちょっと低く、ちょっと低く。うん。もう一回ちょっとテスト。はい。低く。OK、インフレーション。2、3、4。OK、8。
Ik wil nu een beetje
10,
op de borst
12,
wat een stent geplaatst.
14. Depression.
Quality of the injections with the stent in place were very nice.
Thanks.
Yeah,
もう一回14しましょう。
we are very happy with this assist system. It's really very useful, especially with devices in small
14.
catheters.
Okay, it's a depression. Oops. あ、いや、ちょっと抜けてきてる。はい、分割なくても大丈夫ですよ。OK。じゃあ、take a picture. Maybe it's okay.
Okay, still the diagonal is still here.
一応左前。あ、じゃあ、ここ
Yves Louval owes me a coffee.
To show different hemostasis state. To show other hemostasis state.
うん。OK。じゃあ、ですね。じゃあ撮影で。そう、good。そう、エピクライン。いいですか？
We're done.
Check.
I think
It's okay.
it's okay. We have enough images and we need to save contrast for this patient. So thank you very much. What we actually showed here, maybe you can still see the sheathless 5 French, virtual 3 French, and here I think it's very elegant. And since this patient needs to come back for another procedure, we are really very careful with the radial artery. That's why we did the coronary or the coronary angiography with 4 French and the PCI with 5 French sheathless, and now again the PCI of the right. Now the PCI of the LAD is done 5 French sheathless. I want to show you another hemostasis technique. It's different compared to the technique that we use with Terumo. We use that in patients with compromised radial arteries, where the artery is either small or after multiple use, or patients who require future use, patients who had complications with the TR band, patients who have very friable skin. We do something else, and I'm going to show that here. I think we can easily remove, we leave the wire in just to straighten the curve a bit. So, and then I place a little, if it's drops, a little plaster over the puncture side. Nee, nu wel. So. And this is just a simple pile of gauze. We place that over the puncture side to keep the radial artery free. Then the ulnar artery free. Then I remove the sheath or the catheter and allow some back bleeding to flush out possible thrombi. That's what we've done here. And now this is a semi-elastic bandage. We place that crosswise, okay, easier, and over a larger surface actually, in order to prevent prolonged local pressure on the radial artery. And I'm going to show you a very funny feature. Patients tolerate this quite well. You can leave this on until the next morning. Maybe the nurses need to readjust it a little bit by loosening some windings. But if we do pulse oximetry here on the patient's index finger, for example, I hope you can see it. There is a curve appearing. Okay? And now, if I press on the ulnar artery, the pulse is disappearing. Okay? So that means that the radial artery is completely occluded. It's completely occluded. But later today or tomorrow morning, if I do the same, you will see pulsations in the radial artery while occluding the ulnar artery. So this whole patent hemostasis idea is actually intrinsically present in this bandage because of the elasticity of the bandage allowed spontaneous decrease of pressure. And I think that's a very important factor. And so far we did we did a Doppler in 80 patients next day, only patients with compromised radial arteries. And actually we only had one radial artery occlusion next morning. And that was in a patient who already started with a radial artery occlusion, but which I opened up to do the right radial, to do a right radial angioplasty. So that patient we occluded. But all the other patients are still fine. And I think this is a very elegant alternative. And the nurses really like this because they don't have to take care of the entry site, and the patients can actually remove this themselves when they go home after a few hours after coronary angiography. So that's what I wanted to show you. And here we end this live demo. We are up to virtual 3 French, and this afternoon we go to virtual 2 French and virtual 1 French to virtual no French and virtual no doctor, and then the show is over. Okay, thank you very much.
That's brilliant.